The supported tenancies that I manage are traditional kind of setups, 24/7 support, sleep-ins every night of the week. People go to day services in the daytime and have full staff support during the evening. And kind of anecdotally over the years, we felt that that level of support wasn't necessarily needed by all the people that were accessing our service. But for one reason and another, when people required a supported living service, that's what we had, that's what people went into. And consequently, we ended up with a mix of a number of people in different tenancies with different needs, some who did need high levels of support and some who didn't. And like I say, anecdotally, we felt that overnight support, particularly sleep-in support, wasn't necessarily required across all our tenancies, but we didn't really have the evidence to back that up, other than staff comments, staff records in daily notes of people. We agreed on a programme of a kind of almost a systematic approach on a kind of incremental basis. We looked at a couple of houses, we felt that we could look at a couple more, we felt we could look at a couple more, and the idea being that after a period of 6-7 months we could pull all that data together and see if it actually showed us what we thought, and then see if we could link that in with social work assessments to provide that different kind of service really, and ultimately get sleep-ins out. I think there is a bit of a health warning with just checking, even though it's a great system and it gives you this really good kind of real life data, but I think what we found is it was very easy to look at it and say, well, actually nobody needs any support there. You see everybody's bedroom doors closed, the staff bedroom's doors closed, and for 7 hours during the night nothing's happening. I think we've been very careful to put that together with what we know about individuals, what we know from social work assessments, risk assessments, and it's very much part of the holistic assessment process really. I don't think we were going to just look at just check in and use that as the springboard to ultimately kind of reduce all our services. At the same time though, what I also began to explore with some of our independent providers through our joint commissioning manager was them kind of looking at the same process in some of their provision. And I'll talk a little bit more about where that's led us in terms of a response service. So it was a kind of two-pronged approach really. We felt that we could probably reduce sleep-ins in possibly 5, maybe 6, but definitely 5 houses. And if independent providers could do about the same, given the reinvestment that we'd need as a response service, we thought we could save around about £40,000 a year, looking at the cost of a sleep-in being about £11,000 a year per house, offsetting that with having to put maybe some additional peripatetic response team in place to respond to that really. So we did the first couple of houses, that looks really good. So what we decided to do was actually roll it beyond the first 5 houses that we thought of really. What we have done is that we have been able to take sleep-ins out of one particular house, backed up by some of the technology that we've got in place, and that's been fairly successful so far. That's been in place for a couple of months. We'll be shortly looking to put another one through the same process, and by April we think we'll have 5 houses with no sleep-ins in at all really. We have linked this very closely in with social work reassessments. I think we found it very, very early. It was really helpful to talk to staff teams and support teams and families and carers and explain about what we were doing really. And that, it wasn't necessarily just about taking away staff support to reduce costs. I mean, what we did find in some circumstances, it actually improved some of the service that we were offering. We found one particular woman that, although she didn't use staff support throughout the night, the indicator in her bedroom showed that she was up and down and up and down and up and down, and actually over a period of time you could see this person's really not getting any sleep at all. And you put that data together with staff records that said she wasn't feeling very well, her mental health was deteriorating. We were able to go back to a GP and say, look, there's a pattern going on here, what can you do to help? So it wasn't just about efficiencies and taking things away, it was about trying to improve what we'd got for the service users we've got really. I suppose as we started thinking a little bit bigger then, beyond the first few houses, we determined that we're going to have to put something in place in relation to an overnight response service. So our first thought was quite small scale. We felt that as we looked to remove staff resources from houses, following reassessment of people, that rather than putting staff members at risk and potentially redundancy and all that kind of stuff, is actually we could use some of those resources to develop this overnight response service. So, we weren't kind of faced with lots of issues from staff members concerned about losing their jobs. I think what we've found over the coming months is as other providers out there have become more interested, other people have started linking into our idea of a response service, and we think potentially we're kind of growing that response service now. We thought it was only going to be for our very small pilot of 4 or 5 houses. It's looking a bit more beyond now, and local social work teams are approaching us about individuals who are living in single tenancies who may need to buy into this service. So from a care call point of view, we're looking at other developments in that respect really. We've got a number of individuals who actually are taking a lot more responsibility for their own lives, whereas we felt that over a number of years we've actually de-skilled a lot of people that we've been supporting because, you know, it's a bit like Chris was saying before, this is the service, so you need to fit into it rather than what are your needs, so let's develop our service around that. The future's really exciting actually, because in Warrington, some of our other services are redeveloping intermediate care and home support, and there's quite a big service restructure going on there. Some of our other colleagues are talking about a wider response service that fits in with that reablement model, and actually our small response service might start fitting in with some of that as well as we go along. I think the danger is as soon as you start talking about being able to replace traditional methods of support with AT and these kind of solutions, your senior managers already automatically jump onto, £80,000 worth of savings, we'll have that. Before you've even got into the, well, hold on a minute, let's try it out, let's get some evidence and let's see what it is, because a saving over here can sometime lead to a bit more support required over there. So there's a little bit of balance that goes on. But I think overall, our experience of Just Checking has been really positive. And I think what we also found is, although we started off looking at just the overnight bit of our support, when we were able to look at the picture of support for people's days, it did start to identify other areas and other times in their day where actually they could do separate things on their own or they didn't need as much support. So it wasn't just about the big bang of taking the sleep-ins away per se, it was about other aspects of their life as well.
Biggest problems I had really, unfortunately, was around the staff that were in the houses, basically. They thought this was going to completely be instead of any of their care that they were going to give. It took us a long time and it's had to kind of come from the top up downwards in a few of the houses, in so much as, you will leave your door closed overnight. This is to staff members that would leave them open, and we weren't getting any proper data as to what was going on. Yes, we could see clients moving around, but we couldn't see if that staff member was actually having to come out to give any real support.
We also, sorry, I was just thinking then, we also had to do some kind of reassurance with some staff who thought actually we were monitoring them overnight as well. So I mean, all we did was put the sensor on the door, so it just indicated when the door was open. In some of the individual bedrooms, we had movement sensors as well, so we could see what they were doing. But we didn't do that in staff bedrooms. No. As much as I might have wanted to see what they were really up to, but no, we didn't do that, did we? No,
the first house that we put it in, and everyone was up high, and it was a house where the clients tended to be up quite a bit anyway. It was amazing. We thought, oh my goodness, nobody ever sleeps in this. Other than the staff member, nobody sleeps in this house. If you put the sensors down low in the room so that it's picking up as people swing their legs out of bed and move around, you're getting a much clearer picture as to when they're actually up and not just tossing and turning in their bed. You had to give quite a bit of reassurance to the staff as well that rightly so, they're worried about their clients a lot of the time. Yes, they're worried about their own jobs, but they're worried about the clients. It's been the same kind of care going into them for so long. And the fact that we're now suddenly talking that taking this care out, they don't see how that can possibly happen. But it has to be that with the reassurances that we're going to put other things in place as well. The Just Checking goes in, a telecare assessment's then undertaken, and we put sensors in that is going to back up the information that we've had from the Just Checking system. And I'd like to still just leave the Just Checking in for a little while we actually see the staff being pulled out, and let's see, do the clients still carry on in their normal pattern, or is it suddenly completely throwing them because there is no member of staff there?
How do you react if there's an emergency then? How are you dealing with that situation? That's my first bit of the question. And how do you actually then activate the response team to respond to that?
There's a couple of things really. I mean, in terms of the response team, It's developed somewhat, but the response team are probably going to be based over at the care call centre. So they'll be the first point of... We did think that other properties in kind of local locations to where the houses were would fit, but actually, when we thought about it, we felt that being based within the care call centre was probably the best place for them. That's the point that the calls would come in straight away, and therefore they'd be, you know, within a 10-15 minute kind of time frame to get out to properties. Obviously, we're working through a lot of individual kind of risk assessments, fire evacuation plans, working through role play scenarios with individuals so they can do some of that for themselves if, you know, a dire emergency occurs. We also have an on-call senior member of staff who's also going to be linked in with some of this as well, so they will be able to get there and respond in a real emergency situation then. One of the keys to this is about being flexible as a provider service as well. So we've just had one chap where the sleep-ins haven't been in for some time, but he's had a bit of a health scare and we actually need to put them back in for a period of time.
The twofold question is what kind of kit's going in and how are you dealing with the training of your staff for the...
But in terms of the response service, what we'll be using is existing members of staff who work within our service area. So what we're looking to do at the moment is, as service restructures go on, there are a number of staff across our areas that are at risk as services get restructured, and they're at risk of either redundancy or redeployment, and some of that falls in with us trying to develop this service. So we'll be using staff members who have got some experience in supporting the people initially that we're looking at. But in terms of the care call operators, some of our provider staff liaise very closely with care call operators, so they've got some familiarity with the people who they're going to be talking to, what their preferred communications about, how they like to be addressed.
Just Checking's been in for quite a few of the houses now, but for the two that we have actually started to pull out staff, the clients within those two houses are really quite self-sufficient, really. So it's mainly basic environmental type telecare that has gone into those houses. The smoke alarms, flood detectors, bogus callers, and the staff, when they are there, get them to use those. You know, as harsh as it seems, the smoke alarm, the fire alarm goes off during the night. Member of staff doesn't do anything, and we make sure that they respond in the right way. Certainly in those two houses, the clients actually were making sure that the staff member had heard it and were going out. So that was great. You know, we could actually see that, yeah, each one of them, they all responded in the right way, they all looked after one another and the staff member. The houses that we're moving on to are going to be, I think, more complicated and more complex. And we may be having to look at, you know, voice prompts, probably property exit alarms, because we've got a couple of clients that now are starting with dementia as well. And then from there, really, how in depth we start to look at whatever else is out there to meet those needs of those clients within the houses. I think we will have to move on outside of just your basic telecare.
Did you have any issues around consent?
The first couple of properties that we've worked with, people have got full capacity, so that's quite straightforward. As we move on to some of the other people that we're going to talk to and work with, yeah, I'm sure that we will. We spoke to social workers, care managers and families about capacity assessments and how we get through some of that. So I think we're yet to wade through some of that. But certainly the first couple of people, the reason why we selected the first half a dozen people to work with was because, you know, they were a fairly able group and very able to understand and give consent to what we were doing. So
I just wanted to know, what was your period of assessment used with Just Checking prior to removing sleep-ins?
Just Checking in each of the learner disability houses was in for at least 8 weeks, if not longer than that. The way we've worked with the two houses that we've used at the moment, because again we're talking about fairly able-bodied with not a huge amount of problems, so long as we got to the stage where we were happy they were going to react in the right way to the different sensors going off, and that they were quite happy, they will go to the box and press it and speak to the operator if they need somebody. It wasn't in place. The Just Checking had been removed, and then we removed the sleep-ins once everything was in, and we were at a stage where we felt they were quite happy. With the other houses that we're going to move into, because the clients within those have got more complex needs, I want to be leaving the Just Checking in so that we've got that as a backup information as well.